Hi, everyone. Welcome to the evidence-based practice kickoff series on SBIRT for adolescents. We will get started in just a minute here. Go ahead and introduce yourselves in the chat box. Let us know where you're from, both organization and state, so that we know who we're talking to. My name is Katie Volk, and I am one of the site directors for the New England Mental Health Technology Transfer Center. Today, we are going to be talking about SBIRT for adolescents. And before we begin, I have just a few housekeeping notes. Please remember to mute your speakers if you're calling into the webinar, and then remember to mute your microphones as well. The computer speaker can be muted by pressing the key on your keyboard or by pressing the little green horn at the top of your screen above our heads. If you have any questions during the presentation, certainly use the chat box on the bottom left-hand side. We'll leave time at the end of the webcast for Q&A for sure. This webcast is being recorded and it'll be archived on the MHTTC website, which we'll share with you in a few minutes. You'll be able to review the chat box, rewatch the presenters, share with your colleagues, etc. If you have any technology questions, you can also post those in the chat box and one of us will be sure to get back to you. So as we're diving in here, let me give a little bit of an introduction to the New England MHTTC. We are a SAMHSA-funded entity. We focus just on New England. Our mission is to provide evidence-based materials and promising practices to the New England states. It's a really interesting mandate that we have because we are responsible for looking at New England as a whole region to figure out what is going well, how people can share across the region with one another, and then also to take a look and see what we can provide that would be helpful to build the capacity of the mental health workforce. Our deep focus is on recovery-oriented practices and supports. That's something we bring to everything we do just from a philosophical stance. Our team consists of people from the Yale Program for Recovery and Community Health, C4 Innovations, and Harvard University's Department of Psychiatry. Laura and I are both from C4 Innovations and are very excited to be here today. As we dive into this series, which is going to focus on evidence-based practices, I wanted to say a word about why SBIRT, which stands for Screening, Brief, Intervention, and Referral to Treatment. We, at the beginning of this initiative, conducted a needs assessment. Perhaps we talked with some people. I'm looking at the chat box here. We may have talked with some people in your organizations, and SBIRT came up again and again as something people were using or thinking about using. And our real focus is around mental health, and SBIRT has a lot to do with addictions, which is actually what we'll spend some time talking about that today. However, because especially for adolescents, there's so much crossover, there's so much co-occurring mental health and substance use, this felt like a really good way to introduce this series, to have this conversation. And also, as Laura will explain, highlights what the difference is between an evidence-based practice and a best practice and a promising practice. And we'll get into some of that nuance as well. And so sit back, relax, enjoy the presentation. I'm going to turn it over to Laura to introduce herself and look forward to chatting with you all over the course of the webcast.
Thanks, Katie, and thanks everyone for having me. I'm excited to talk about SBIRT today. My name is Laura Winn. I am a Deputy Director at C4 Innovations, and I'm also co-principal investigator for a study on an intervention called Project AMP, which is an intervention that utilizes young people in recovery in an SBIRT booster for adolescents at moderate risk. So I'm really coming from that perspective of our work implementing SBIRT in school and clinic-based settings and designing additional supports for youth, leveraging the expertise of young adults in recovery. And I'll talk more at the end of our webcast about what Project AMP is all about as one option or innovative practice to expand and address some of the challenges that we see with adolescent SBIRT. And I'm excited to see you, Gregor, from Colorado. One of our sites was in Aurora, Colorado, so I might be able to chat more about what's going on in your state. I live in Milwaukee, Wisconsin, so not in New England right now, but I have lived in Boston and missed the area quite a bit. Even seeing some of those pictures and the slides that Katie shared made me miss it, especially this time of year. So our call today is about SBIRT, as Katie said. So we'll talk a little bit about adolescent substance use risk and trends. We'll talk about what SBIRT is, the advantages of SBIRT for adolescents, some of the challenges that we've seen. We'll talk a little bit about the evidence for adolescent SBIRT, and then we'll close sharing a bit about our work with Project AMP. This project, and then, sorry, I just saw Tiffany chime in here in the chat box from Georgia, which is wonderful to see as well because one of our other sites was in Marietta, Georgia. So a lot of great connection with the Project AMP work. So this webcast is meant to be an introduction to adolescent SBIRT. It's not a practical training on how to do SBIRT, although I'm happy to provide resources on that. It's not a complete review of the literature or a primer on financing strategies. These are some of the things that come up on questions, and I'm happy to provide resources on that. But it's really just meant to be an overview and an introduction and to provide some resources to dig in deeper. So let's start with talking about adolescent substance use. Adolescent substance use is not something that is without consequence. I think culturally it's been normed quite a bit as a common experience of growing up, and for many it is. But I think it's important to remind ourselves some of the statistics around adolescent substance use. So approximately half of 12th graders have used illicit drugs, and about half have been drunk at some point in their adolescence. We're seeing a big rise in vaping, tobacco vaping for adolescents, and along with that a rise around vaping and with marijuana. I think any of us who work with young people have seen that trend sort of explode over the past few years. And this kind of use, again, isn't without consequence. The literature shows us that as use increases, and also the earlier that use begins, it increases the likelihood of developing an alcohol or substance use disorder later in life. One statistic that I have here is that it's 5 times more likely that teen use of alcohol before the age of 15 will result in substance use disorder and risk of other disruptive outcomes later in life compared to later initiation of use. And some of those disruptions and outcomes include a correlation of substance use with accidents and injuries for adolescents, decline in school performance, family conflict, unprotected sex and other risky sexual behaviors, involvement in criminal justice, as well as morbidity and mortality. So I think it's important just to remind ourselves that while adolescent substance use is something that we see as common, in fact, many adolescents don't use substances and is associated with some higher risky behaviors. It really is, substance use really is an issue that has its root in adolescence, and so it's important to address these concerns early in life. It's been encouraging to see that over the past decade, adolescent substance use has stabilized overall. We haven't seen large jumps in rates of use, and some of the prevention strategies that we have seen have shown to start to show some efficacy, which is wonderful. Within that sort of flat line, we have seen some changes again, particularly around vaping. And we're also seeing some new cultural trends that I think could have the potential to impact that trend as well. So legalization of marijuana, and along with that, the language around marijuana in terms of it being natural, it being something that's a lot of positivity around that use, especially for adults. I think there is some concern and some trends pointing towards increased use for adolescents. Vaping is absolutely on the rise. Increased access to opioids, that's not a surprise to anyone, as well as cultural shifts again around sort of a norming of adolescent substance use as a rite of passage. We see this in surveys with providers and educators as well as parents. And also, I think that there is a shift in language around how we think about adolescent health. And I think particularly around behavioral health issues in general. I think there is an increased language and understanding of whole health wellness and holistic care. Many of these issues, as Katie said, are co-occurring. And they're not just co-occurring, but they're feed into one another. So oftentimes adolescent substance use is a symptom or a mechanism to to cope with some of the everyday challenges and anxieties that come along with adolescence. And some of these, the research around anxiety levels for adolescents, are showing an increase there. And so substance use is knit along with that. So given some of these trends, we're seeing a rise in new approaches to care for adolescents at risk of substance use or substance use disorders. SBIRT isn't new per se, but it is emerging and it's growing in interest and popularity in research. And so let's talk about what SBIRT really stands for and what it's all about. As Katie said, SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. And in its simplest way to explain it, it's really a process to identify and respond to risk of substance use. So screening, it's really about a universal screen, so for an entire population, whether it be adolescents or a specific class or everyone who's coming in for a well visit, depending on the context of the setting, using a validated screening tool to assess risk and use. Based on that screen and the risk that's indicated with that brief screen, it points to an appropriate response. So that would be the brief intervention. For those who don't have any indicated risk based on their screen, positive reinforcement is used. But for those who do indicate risk, a brief motivational awareness-raising intervention is employed. Sometimes that's brief advice. Other times it's a more intensive evidence-based brief intervention. And then for those who are at a higher risk, and would benefit from a referral to additional support to treatment, that's where the referral to treatment comes in, typically to specialty care or other supports, outpatient treatment, counseling supports, things like that. SAMHSA defines SBIRT as a public health approach to the delivery of early intervention and treatment services for people with substance use disorders and those at risk of developing disorders. And I think the important thing to note with this definition is that it's a public health approach. So rather than providing resources and support to those who have indicated risk, it's really about treating the whole population in a more holistic way. So assessing risk across the board and providing appropriate responses. As well, SAMHSA has recommended that SBIRT be used as a part of routine health care. And we'll see that across other government agencies and accrediting agencies that SBIRT is being promoted as a best practice and recommended for use. So it's helpful to think about SBIRT in contrast to usual care, and a few items here that I want to highlight that help to highlight those differences is that SBIRT uses a universal screen regardless of indication of risk. Oftentimes it's used, like again, at a well visits for adolescents, at a health class or at intake at a school-based health center. And the universal screen is important because it identifies individuals at all levels of risk, and even for those who aren't at a stage of use, that early conversation, even within a screen, has protective results. And that's distinct from usual care, where screening, and this is from surveys with physicians, is often inconsistent and only is initiated when there's some indication of trouble going on with the adolescent. The screenings are validated and standardized, whereas without SBIRT, oftentimes these questions come in a non-systematized way, and so they're not evidence-based in their approach. SBIRT also thinks of substance use as part of a continuum. So where are you in terms of your use and risk, rather than do you have a problem or not, as more of a dichotomous approach that we would often see in typical care. And so if there is no, quote, problem, there may be no response to sort of an early stage of use. SBIRT also utilizes evidence-based person-centered change talk as a way to respond to indications of risk, whereas what we would see more in typical usual care can be more directive communication, which particularly for young people is less effective. And it facilitates an integrated holistic model of care. So again, as you're identifying folks with sort of a range of risk and thinking about responses that are appropriate to that risk, it introduces a more integrated approach to care rather than sort of more uncoordinated or cold handoffs based on higher risk behavior. So where do we see adolescent SBIRT? We're seeing it kind of pop up all over, which is great. It was initially designed and thought of as an approach within healthcare settings, so primary care. There's been research within emergency care, school-based health centers. There's a lot of work going on through some organizations around school-based health and SBIRT. And so these are completely appropriate settings because of, of course, the conversations that happen around health overall in these settings. It's also a great place to capture young people kind of at all levels of risk because many young people are coming in for routine health care. There's increased training for health professionals within medical schools, nursing schools, additional add-on modules that are being developed by some organizations to train health professionals in SBIRT. There's federal support for SBIRT within healthcare settings. Again, recommendations from SAMHSA. It's in many states a billable service for Medicaid by private payers. And the American Academy of Pediatrics has issued a statement recommending SBIRT be used in a universal way. We're also seeing it emerge in school-based settings quite a bit. In some states, including Massachusetts, it's mandated in public schools now. There are pilot programs in other states, Wisconsin, Indiana, New Mexico, where school-based health or school-based SBIRT is being tested and piloted. We're typically seeing it delivered through the school nurse, the guidance department, again, school-based health centers, or through partnered behavioral health organizations who work within the schools. There are often models where there are community-based behavioral health working with schools to provide support for the students at higher risk for behavioral health issues sort of across the board. And so SBIRT is a kind of appropriate continuation of that support. And again, there are mechanisms through Medicaid and other payers to support SBIRT within the school-based settings. Not always easy, but it can be done. So let's talk a little bit more about the nitty-gritty of how SBIRT works. And we'll start with screening, with the S. So screening is done with a validated screening tool. There's a number of different tools out there. Typically what you're looking for with SBIRT is something that is brief, can be done quickly. The CRAFT has probably been the most common that we would see in adolescent SBIRT, and I'll talk a little bit more about that. But S2BI is an emerging approach. The BSTAT is another, and of course, I'm sure you're all familiar with other screening tools. And again, the important thing with this is that it be validated, evidence-based, brief. Oftentimes, if a brief screen indicates risk, and a longer assessment can be used, but it should be brief within the SBIRT framework. And these tools have had enduring sensitivity to substance use risk, which I think is important to point out because there has been some changes in the DSM around indications for substance use disorders, and these tools have endured through some of those shifts in terms of identifying risk for substance use disorders down the road. Here's an example of the CRAFT tool if you're not familiar with it. So this is, again, is one common tool that's being used. It's been adapted since this version, but it has a three-question start. So have you used alcohol, marijuana, or anything else to get high in the past 12 months? If indicated as a no, you would ask the first question. So have you ever ridden in the car with someone who was high or been using substances? If they indicate yes to any of the first three questions, you would ask the following 6 questions, and that's really where we get to the CRAFT name. So have you ridden in the car with anyone? Have you ever used substances to relax? Ever used them to be alone? Do you ever use them when you're alone? Do you ever use them do you ever forget things when you're using substances? Have you ever gotten in trouble while you're using substances, and has your family or friends ever told you need to cut back? And so, it just sort of gets at some of the core things that might be going on in a young person's life as a result of substances, and then based on that score, sort of indicates risk. So that's just one example. So here is a table that helps to sort of think about where these scores might fall along the DSM diagnostic criteria for substance use disorder. So if a 1 is a lower probability than a 6, of course, for a substance use disorder risk. And so for those who would fall under a 2, they would be considered at moderate risk. Anything above a 2 would be considered high risk. And so, again, it's just a helpful way to sort of identify risk criteria and then from there identify an approach. So you can see this tool doesn't talk about frequency of use. It doesn't get into other indications of risk, but it's a means to sort of begin the appropriate next conversation. So let's talk about screening a little bit more in terms of what we might see in terms of the rates of high and low risk. One thing I'll note is that it varies quite a bit. While it's consistent across the board that the majority of young people would screen at a low risk, so either indicate as sort of 0 on the screen or very low risk, that's the majority of what you would see. Again, there's a lot of variation amongst different settings, age levels, different populations. Some of the research would indicate that as many as 80% would fall within the low risk categories, sort of 0 score. Others are around more 58%, and so it really does vary quite a bit. There's also some variation amongst the mode, so there has been some research around, if it's delivered electronically versus in person, different types of providers, different types of settings, we see some variation there. And then the percentages sort of reduce as you go up the scale to severe substance use disorder, so those that would fall within the high risk category, and those range between sort of 15 in some settings to as low as 3% in others. And the reason I wanted to point this out is sometimes there's quite a bit of concern about initiating substance universal screening in certain settings because the worry is we'll identify so many students or so many patients who need additional supports and we're not prepared to provide them. It's an important question, I think, to ask because, if you don't have the supports there is a concern about identifying a risk. You want to have the next step in place for that person. But oftentimes those who are needing those additional supports is a lower percentage than what some expect. And again, it varies quite a bit by site and setting. So here's an example of an algorithm and how to respond to the screen. This is the S2BI, which is a frequency screen followed by an assessment of risk. And so, for those who indicate no use, again, a positive reinforcement is appropriate. So, just engaging in conversation around how that, that's kind of an appropriate place to go, and sometimes a conversation around risk that could be expected should use be initiated is appropriate, as sort of information around risk is an evidence-based protective approach. And then as frequency increases, the response can change. So for those who indicate very low use, brief advice is appropriate, doing some follow-up assessment questions as well to get a better sense of that. And then those who are at more of a monthly or weekly use, the appropriate response would be in that BI category. And really the goals there are to reduce use and risky behaviors for those who are kind of in the more moderate range, and then those who are in high range to really have a conversation about what the next steps for that person might be in terms of engagement with additional supports. But again, that BI is important for that group, and I'll talk a little bit more about that. So after screening is brief intervention. So again, depending on what the risk score was, there's an appropriate response following the algorithm for these SBIRT models. So for moderate, brief intervention is appropriate for moderate risk. It's also appropriate for high risk to sort of move them along that change conversation process towards initiating other engagement with referrals and support. BIs can be as little as just a few minutes, depending on where the young person is at in their use and their engagement in the conversation, but the average is usually around 30 minutes. Again, they're motivational interviewing-based conversations, which is based on evidence-based practice. There are different models out there, but they are all similar in that they initiate a reflection of their use and where they're at, a motivation to change, so really identifying, what is this use sort of doing for you? What challenges maybe has it initiated? Where do you see yourself going? And motivating that change towards reduction in use or lack of use. and then initiating a change plan so that they have a next step and goals in mind for moving forward from the conversation. Brief interventions have been shown to be effective in various settings and in various ways, even the very brief ones, which is encouraging, but there's quite a bit of variation in how BIs are used within SBIRT and typically not well monitored, and that's one of the issues I'll raise later around where we see some challenges with the evidence base for SBIRT overall. So the last step in the SBIRT continuum is that referral to treatment. So for those who are indicated at a higher risk, offering a referral to outpatient counseling or treatment supports. It's also an opportunity to consider talking with parents with their permission. And that referral to treatment, it varies again quite a bit based on setting. So if the referrals resources have to be in place to be able to make that referral, right? So communities differ in the treatment options that are there. Schools and clinics differ in the clinical supports for substance use that are available. And so it really looks different based on the setting, the time that's there, and the resources within the community. I think for adolescents too, some of the conversation around SBIRT has shifted around not just referral to treatment, but referral to supports. For those who are even in the moderate risk range, having a next step and a connection to something that's positive and supportive for them is really key, not just thinking about it narrowly around treatment. Also, this parental engagement is an important point that I want to raise too. So something that we run into a lot, particularly within the school-based setting, is a discomfort with a confidential screen around substance use with a minor. But it is so important and recommended that that screen remain confidential for the security of the adolescent and for the ability for them to speak honestly about what their use is and to open up a conversation to engage about potential engagement with parents or other supports in their life as a next step. It gets complicated when you think about mandated reporting requirements and higher use, and it goes hand in hand with some of the other policies. But that initial screen, it's important to maintain confidentiality. I'm happy to talk through questions around that later if you like. So let's talk about some of the advantages that we see with SBIRT. One of the advantages is that you are able to screen many young people quickly. It's meant to be a population-based approach, something that can be integrated into healthcare visits, into school time. It's meant to be brief. And so it's a great approach to think about, if you're wanting to get a sense of the population use and engaging with those who are at an early stage. It's meant to be brief. It also has a lot of advantages in that it can identify those who would be otherwise unnoticed. So early use or those who are at maybe a higher risk but are not getting into trouble about it, or if it's thought of as like a more social thing and hasn't been indicated as a problem. These screens have shown to identify youth that have otherwise gone unnoticed. And it's important, again, to recognize that that may mean that for the systems that you're working in, that it would increase engagement with additional supports, behavioral health supports, and for some settings, that's a concern if resources aren't there to do that. So that's always something to keep in mind when you're considering launching into SBIRT. Again, you can find cases of initial stages of problematic use prior to abuse or dependence, so not waiting until it's a quote problem, but getting engaged at an earlier stage. And it provides an intervention in a short amount of time. Again, the ideal is to keep people engaged over time, especially young people, but these brief interventions, these one-time interventions have shown to have a protective outcome for young people, and so it's an opportunity to start that conversation with a young person. And it can help close the gap between treatment need and utilization by enhancing motivation to change and facilitating access to treatment. So for many young people or anyone, at their stage of use, it's really about connecting the dots for some, especially at an early stage. So identifying that motivation to change and making that connection to additional supports. And SBIRT can help facilitate those connections in a more holistic and integrated way. So let's talk about some of the challenges that we see with SBIRT. Many of these come from the fact that it's been normed with an adult population. So a lot of the early research that came out around SBIRT and where it falls within sort of an evidence-based criteria is with an adult population within emergency care who are at risk for substance use, alcohol use issues. And many adaptations and research has come from that early work. But the model itself has been normed with an adult population. There's also great variability in how SBIRT is done. I think a helpful way to think about this is that SBIRT is a process. It's a process of identifying risk and responding appropriately based on where they fall within that continuum. It's helpful to think about it as a process versus as a really self-contained model. And because it's a process and not a model per se, it presents a lot of opportunity for variability. The screenings can differ, the BI approach can differ, and in many ways that's appropriate. You know, it's responsive to the needs of the young person. But because of that variability, research has been a challenge. It's been hard to validate SBIRT because it can look very different. So within the scope of SBIRT, there are evidence-based screening tools, evidence-based brief intervention approaches, and of course treatment. There's evidence-based around treatment approaches as well. But taken together, some of the validating or the bodies that identify evidence-based practices have placed adolescent SBIRT as having emerging evidence and requires additional research. And we're seeing that, which is exciting, and I'd be happy to share where the research is at with articles that are coming out. But it's important that we see more of this research happening so that we can sort of identify what's working for adolescents, where some of the additional challenges are, and how the practice can be improved. Providers often lack time in implementing SBIRT, so that's a challenge that we see as well. There's been some surveys that have come out of Massachusetts in particular around some of the SBIRT practices that providers employ, and they did identify as lack of time, and they have a lot to do within that brief healthcare visit with their patients. And so to start a conversation, to use a validated screening tool and to start a conversation around substance use doesn't always make it to the top of the list. And even we learned in some of our SBIRT implementation work that even when the will is there, it still can be hard to get off the ground because there's so many competing priorities. Physicians also indicated that they lack confidence to know what to do when there is a positive screen, if they haven't been trained in some of these practices around substance use prevention and early intervention. If they're not comfortable with some of these issues, sometimes it's easier not to ask, not because the care isn't there, but because, again, time is limited anyways, and if I'm not sure how to respond, I'm not sure I want to ask. And related to that, if there aren't resources in place for those who are at higher risk or those who need additional support, again, not asking the question can be sometimes feel more appropriate than asking if we don't have a next step for that young person. And so some of these challenges have pointed to the demand for more developmentally appropriate adaptations of SBIRT. There's been some literature coming out around this. Some of the recommendations or emerging discussions that we're seeing around adaptations are longer multi-session BIs for adolescents, BIs that include parental engagement with permission, different provider types to engage in these conversations to increase relatability with young people. And so these conversations are emerging, and again, we're seeing more research initiated around some of these models. And so I'll talk about, again, Project AMP, one of those potential adaptations here in a little bit. So let's talk about the evidence a little bit more. As I said, it's emerging, but we're definitely seeing a lot of activity in this space. We're seeing research within school-based settings. So there's been some good research coming out of public and middle and high schools in Massachusetts and Wisconsin. I see one of our attendees is from Massachusetts. Some of the research coming out of some early pilot work prior to the state mandate around SBIRT in Massachusetts. There's also some good work coming out of the state of Wisconsin around school-based SBIRT. There's research from school-based health centers in New Mexico and New York around Adolescent Efforts, which is interesting to see. Some of it around outcomes, but also implementation strategies. And then some work coming from primary care providers in New Hampshire as well. And again, that's not an exhaustive list, but a few examples. There's also a systematic review that recently came out that helps, I think, to describe the evidence base really well. I mean, and a few of the key points are, SBIRT can effectively identify youth at risk of substance use, and that but the effectiveness of brief intervention component was inconclusive. And again, that's because we see a lot of variability in that implementation. The algorithms are not super prescriptive, and there's a lot of flexibility in the approach to those motivational interviewing-based conversations. And so again, it's hard to create a validated evidence base around some of that. And so as a result, SBIRT has an insufficient evidence to support long-term effects in illicit drug use and limited research on the costs and benefits for substance use in adolescents. And that's not to say that it's not working, that's just to say that we need additional research to explore adolescent SBIRT further. I think the cost-benefit question, too, is really interesting. There has been some literature around how it can reduce costs, but the upfront costs to really get it going can be high. And so, again, it might require some adaptations when thinking about the workforce population to address some of these challenges. All right, I'm moving along quickly, so I think I'll pause there and answer any questions we have generally about SBIRT, and then I'll dive into some of the project AMP work. So if you have any questions, feel free to put them in the chat box, or I don't know if we can open the lines for questions now, and then again, I'll come back to the project AMP work here in a minute.
So Laura, this is Katie. While people are just gathering their questions, I have two that did come in here. One of the questions I had is, well, I have a few. One of the questions I did have was around what level of expertise people need to have in order to implement it, because I know one of the things that certainly the behavioral health force bumps up against is clinical versus not clinical, trained versus not trained. Could you speak a little bit to that and who exactly is doing it in a little more detail?
Yeah. So typically, SBIRT is done by a clinically trained provider. So that would be, a credentialed social worker, nurse, other healthcare providers in the guidance counseling field. And the SBIRT trainings that I've seen have typically been multi-day trainings with booster trainings as a follow-up. There are, again, some modules that are being developed for nursing school students and things like that. So it kind of depends on the training institute that you're engaged with to do SBIRT, the length of the training that it takes. I think what it really comes down to is some of those MI skills that some have more naturally because of their role, and some have been trained in, and others need a little bit more time to do effectively for that BI stage. And so there's that kind of one-to-one training that's necessary. And again, we've seen it more so with clinically trained providers. And then there's just the time that it takes to implement something like a universal screen. You're figuring out within the workflow, where does the screen come in? Is that the same person who's doing that screen who's also going to be doing the BI? What would that handoff look like if there was? How do we figure out how to bill for it if the billing is an issue? How do we figure out how to match those referrals if it's an issue? And so I would say what we've seen with schools and clinics who are interested in launching SBIRT or clinicians within their setting, that it can take up to a year to really kind of figure out all the quirks and nuts and bolts with that. While we've seen SBIRT delivery more typically with clinical providers, something that we're exploring and we're seeing emerging is paraprofessionals in a role to initiate that screen and BI, and then bringing in clinical support as needed for those who are in need of it. That's definitely still emerging, and we're seeing more conversations about peer roles for that, but I would say that that's not typical at this point.
That makes sense.
That makes sense. Mm-hmm. Other questions?
Another question that I had come in, just because it looks like the chat box is a little quiet, but I've been getting some messages behind the scenes, is about the confidentiality and liability, and how you've seen, if you could say just a little bit more about that. I think that's certainly an issue that popped into my head when I was thinking about this. And does it make programs nervous? How do they engage parents get on board? I'm curious about that piece.
Yeah, I mean, obviously there's regulatory component to this, but I've seen there's been a cultural shift too, even since we began our work probably about 5 years ago with working in schools in particular, where we see this, is that initially it was like there was no, not a lot of openness to doing a screen without parents being engaged at any indication of risk. And that really follows kind of a more typical punitive model that we might see in schools or something where, if someone gets caught drinking, they're immediately suspended, they might be kicked off the football team, or, that's been the approach that has been more normalized over the past number of decades. And I think that we have been seeing a shift where there's a recognition that this isn't a whole health problem, and that substance use isn't necessarily just sort of like rebellious behavior or breaking the rules, but it can be an indication of having other needs, and that the consequences, can be higher than what, with some of the substances that are being engaged with than we've seen too. And so the model has been moved away from initial parent engagement, early parent engagement, suspension, punitive results, but more of a let's bring that young person into a conversation about what's really going on, what their needs are, and how we can respond. So again, that's kind of like an earlier question to then, okay, when and how do we get parents engaged? But I think it's an important cultural shift that we're seeing that provides context to what we're seeing. On a more practical level, it varies state by state in terms of age of consent for treatment, and so that is an important piece as well. So if someone does indicate at higher risk, they want to engage in treatment, many times for minors, parents have to be involved. Even if they don't, if they're on their parents' insurance, that can be indicated for the parent, and so being very clear about, very transparent about when a parent needs to provide approval is key. From a liability standpoint, I mean, a universal screen has become more and more standardized in terms of its confidential nature. And so what we've really framed it out as is it's a way to initiate a conversation that may not already be happening, and an opportunity to engage parents as led by the student. And then, of course, mandated reporting requirements can help kind of provide some transparency as well around, like, at what point do parents need to become involved. So again, it depends on the settings and also the regulations within the state on how that can be navigated.
Great, thank you. Yeah, one of the things I really appreciate about SBIRT is that I think when you conduct universal screening, you minimize bias in so many ways. It's never perfect, but I've heard story after story of people assuming, well, those are the kids with the substance use problems, and forget about these other kids over here, and it's all based on personal biases and stereotypes and things like that. But when you screen universally, it does so much to just reduce stigma, in addition to all of the other wonderful things that you've talked about. And I also think it opens up an opportunity to have a conversation about mental health needs and about substance needs in ways that may not have otherwise come up. Because like you said, substance use, I think, can often be a symptom of so many other deeper issues going on as well for a young person.
Exactly. So to have those few minutes to connect with someone who knows how to have these conversations, even as, if the screen is 0, but you're in front of someone, you can really begin to create that connection. Someone to come back to, if this is something that comes up, later down the road. So yeah, there's a lot of great protective elements to having that initial conversation.
Well, if there's no other questions, I'm not seeing any come through the chat box. It's a good segue into Project AMP.
Cool. Thanks, Katie. So Project AMP is a study that we have been doing for a number of years now, and I'll describe about what Project AMP is all about and then some of the research that we're doing with it. So Project AMP is a 4-session, 4 one-hour session intervention that's one-on-one between a young adult who's in long-term recovery with adolescents between ages of 13 and 17, and a one-on-one approach to really build on the BI stage within SBIRT. So for young people who screen at moderate risk of substance use, very often there are few supports for them. Again, there's a kind of a brief BI that can be offered, and then those who are at higher risk, a referral to treatment may be appropriate. But for those in the moderate risk, there's often sort of not a next step. And so what we've sought to do with Project AMP is explore how young adults who are in long-term recovery might be able to fill that workforce gap within that stage of use. And so Project AMP is guided by a manual, which includes example scripts and a flexible approach to walking through some of the goals of Project AMP, which I'll talk through in a minute. But the goal is to try and have a conversation over the course of 4 sessions with a young person who wants to, just talk with you, figure out, what your goals are, where you see your life going, what some of the challenges you're experiencing in a more structured way to be able to connect onto long-term support. We get that 4 sessions isn't a mentorship model per se, but it's a lot more that happens typically within that brief BI. And so, our goal is to try to figure out a way to enhance that engagement with longer-term supports through a 4-session intervention. So it's really, we've been using the CRAFT screening tool for our phase 1 research for those within the moderate risk as defined as 0 to 1, and now for phase 2 we're expanding the eligibility for those who fall within a score of 0 to 3. So some who are in that slightly higher risk, but all along the kind of early use spectrum. And so again, Project AMP, while it's brief, it's more extended than a typical BI, and our goal is to offer connections to ongoing support. We work with peers who are in recovery because they have relatable experiences to those early, early experimentation, struggling to cope with adolescence, the early temptation to use, trying to figure out how do I get through this stage of life. And while their path took them on the path of substance use dependence and recovery, they can really relate to those early stages of need. And they're just more relatable in general. And we did a lot of focus grouping with young people in recovery, but also teenagers who would say, if I had someone who kind of looked like me, who's been there, I would absolutely talk with them. And maybe it would have made a difference for me in a really distinct way from a clinical provider. Also, the skills that are developed in recovery are very similar to what we see in terms of protective factors for prevention. So young people in recovery are good at setting goals and meeting them. They have worked on their wellness and developed strategies to maintain their wellness. They know how to have fun in a sober way and develop positive social connections with those who don't use substances. And they've developed strategies to cope with common stressors of life. And these are all things that we want to see, in terms of prevention and early intervention approach to substance use. So some of the pushback we get around Project AMP is, why would you connect someone who's at an early stage of risk to someone who, has had all of his experience with drugs and alcohol? And so what we do with our mentors is really train them to frame that recovery experience from a prevention standpoint. And we've seen a lot of great feedback and outcomes from that work. We also think that young adult peers have a lot to bring to the table in terms of expanding the workforce capacity around SBIRT delivery. So again, some of the challenges that I mentioned before was that physicians and clinicians don't have a lot of time to do something extra. It feels like extra, if it's not something that's been a part of their standard practice. They don't have a lot of confidence in initiating these conversations sometimes, and they're not quite sure where to send folks. And so well-trained peer in recovery can be kind of a new untapped paraprofessional workforce to engage in that SBIRT process in an integrated way. And so that's one of the other things that Project AMP is trying to put forward. So we launched Project AMP with a feasibility study a few years ago in 3 school-based settings and 3 clinic settings. We were sort of learning as we go. It's definitely an emerging model, and so we had some implementation challenges, which impacted our overall population for our sample size. So our results were not statistically significant in terms of the sample, but they were pointing in favorable directions. So for those who did complete the study, indicated positive factors around self-efficacy scale, perceptions of harm around substances, indicated improvements in terms of social supports, as well as changes in CRAFT scores over time. So for phase 2, we're launched that back in December. We're doing a larger randomized controlled trial, specifically within schools. We saw some challenges to have adolescents come back for 4 sessions in a clinic-based setting, but if we're integrating them to schools, it's a little bit easier to do a multi-session intervention. We're looking, of course, to engage a larger sample size and doing a randomized trial, and to include some adaptations from our lessons learned with phase 1. So that not only, again, includes expanding eligibility criteria, working in schools, but also really integrating that young adult peer into the sort of fabric of services and supports within school-based settings, so that it's not just a referral, but really an integrated role into the SBIRT continuum. And so we are currently looking for school-based sites and partners to serve as research settings. So I thought I made sure it was okay with Katie to say, like, if you're interested or know of schools who might be interested, please reach out to me. We have the manual from phase 1, videos with mentors, all sorts of resources for implementation and outcomes on our website, projectampforyouth.com. So if you're interested in learning more about it, you can go to that website, and Katie just popped my email there in the chat box to get in touch with me if you want to learn more. I also have a lot of SBIRT resources. If you're interested, I listed a few on the screen here. I'll go ahead and go there. So some of the resources that I referenced in the presentation today around SBIRT, there are links here that you can probably get with the slides that would be shared with you. I'm also happy to send anything to you along with some of the research articles that I've mentioned, and other resources around training, things like that. So happy to share anything if it would be of use to you all. So with that, I'll pause again for questions around Project AMP, any additional questions for SBIRT, and then I'll hand things back over to Katie. And if you have your phone mute, go ahead.
Yeah, one of the things, I think my phone might have been unmuted there. One of the things I'm curious about is how you all might see SBIRT working in your setting or not working in your setting, what you think the opportunities and challenges may be. I can put you all on the spot here. Everybody's having a shy kind of day.
I see someone chatting there in the chat box.
Oh, there we go.
I think I see a few folks too here who are representing the recovery communities. I think there's a lot of great opportunities for recovery communities from that peer perspective, be more engaged in prevention, early intervention. SBIRT, I think, is a mechanism to do that, which is exciting. So I see Susan is sharing that they're looking to implement SBIRT in a youth and young adult drop-in setting. So as Susan is writing, you know, in our early inception of thinking through peer-based SBIRT, you know, we're thinking about healthcare settings, school-based settings, and my mind has also gone to community-based settings like youth and young adult drop-in settings where young people are there every day often, like Boys and Girls Club, things like that, and it's a great opportunity to engage in conversations around substance use, and so SBIRT is a great tool for that. And it's also a great place for young adult peers who are already involved with community engagement to be engaged, so that for something that's a multi-session intervention like Project AMP or Teen Intervene or other models out there, you know, has a good fit. So I'm excited to see if there's some engagement thinking about these kinds of community-based settings. And Susan is sharing that it's been difficult to engage the population by definition, so we want a brief intervention without scaring people away. Yeah, I think that's hard, especially for like a drop-in center where it's usually more social. Initiating that conversation around substance use is a hard ask. At the clinic setting, it makes sense. Like, I'm going to ask you questions about your diet, your exercise. Let's talk about substance use. So there's more of and even within schools, it's a little bit more acceptable. I think that is a challenge. I mean, I'm not sure I have a great response for you other than it has to become a part of the conversation. I would suggest thinking about more primary prevention approaches as a starting point to start to have more casual conversations around substance use at the drop-in center. So if we're starting to see more messaging, bringing a young person in recovery in to start to talk about their experience in terms of prevention from that standpoint, it can kind of be a way to remove the barriers to start talking about SBIRT or start talking about adolescent substance use as a means to sort of build buy-in to say, like, let's start talking one-on-one about that. What does that look like for you? Can I ask you a few questions about your use? Another great way to think about that in terms of if you bring someone in recovery there to do some sort of assembly style or conversations around substance use in a more general way, if it's that person who's engaging in SBIRT, it reduces the barriers to start to say, like, well, can I ask you a few questions about you, and I'd love to come back and talk with you again about it. So again, I think it's normalizing the conversation, developing a dialogue around it prior to saying, okay, now we're doing a screen, which feels very scary and potentially punitive.
I do think too, one of the things we've seen, I was just going to say, one of the things I've been seeing in communities, at least anecdotally, that have been hit hard by the opioid crisis is that it's definitely on young people's minds in a way I think that it hasn't been before, and I've seen that be able to open up little cracks into little opportunities for conversation and can be a way to engage people, because it's certainly, at least in the communities, I'm in southeastern Massachusetts, and at least in the communities that we're visiting, you feel it quite a bit, high school and kind of even post-high school levels. Yeah. And so it looks like Gregor is saying SBIRT and school-based health clinics were funded in Colorado through SAMHSA. Yeah.
Yeah, Gregor, we've seen a number of models of that, Colorado, New Mexico, for example. And I think that's been incredibly helpful, SAMHSA support, to move that forward, and we've seen some success and good research come out of that model. What I'm starting to hear is as those funds are ending, some challenges in sustaining SBIRT in those settings, and so I think I'd be curious if you want to share like how that's going in terms of sustainability, and how clinics might be thinking through continuing with that engagement. Because I think that's something that we see with our own research as well. We get the ball rolling with our support, but it is, a whole new way of thinking about workflow and having staff time to do it, and it can be hard to maintain. Okay. And Gregor, if you are on the phone and like to come off mute, if you want to share your question that way.
You may have all the participants are all muted by the webcast software.
Oh, okay. That's okay, Gregor. Feel free to share with me afterwards if you're not on the phone. But I think, so it's been wonderful to see these approaches emerge in different states and in different settings, and I think now a lot of the conversation is moving towards how can we maintain this engagement as some of these challenges have come into the surface, or questions around sustainability. And there's great work around financing strategies, and I can share some of those too with the resources on the website. So I think with that, Katie, I'll hand things back to you. But again, please reach out to me with any questions that you have. My email here is on the screen. Thank you.
Great. Well, Laura, thank you so much for leading us through that. Really interesting, and I'm excited to see SBIRT take root in other places and see the research base expand for sure. What you've got up on the screen here is Laura's incorrect email address. It's actually lwin@c4innovates, not C4innovations. That is my typo, my apologies. And mine is the same thing, innovates, not innovations. Our name is C4 Innovations. I will update those slides before we send them out for sure. What is correct is our web address down at the bottom, mhttcnetwork.org/New England. That is where all of this information will get archived, both the slides, some of the resources that Laura shared, and what you'll get, we will email you at the end of this webcast, and what you'll get is a link to an evaluation form, so please do go ahead and fill that out. That'll come by email in the next couple of days. I also wanted to let you all know that we, as the New England MHTTC, are offering a whole host of events. You can click on the link on the left-hand side right under my head here where it says MHTTC events, and that'll take you to where all of our events are listed. But we have a series coming up on trauma-informed care. We've got a bunch around a trauma learning collaborative webinar series around different practices in schools around trauma-informed care. We also are offering a lot on early psychosis, which is, I know, particularly of interest to people working with young people many times. We'll be talking about person-centered recovery planning and suicide prevention. So we really have a wide range of activities going on that are open to everyone and free. So go ahead and take a look at those. And thank you so much for attending. And again, just be on the lookout for that email from us, which should come tomorrow with an evaluation link. And that concludes our webcast. Thanks so much, everyone.
Thanks, everyone, for being here today. Have a great afternoon.